Assalamu alaikum, dear viewers. I am Ziad Muhammad Nakshabandi. Today we're going to continue the series of universal topics, and today we're going to speak about an important topic which is probably related to all surgical specialties, which is the preoperative assessment. The learning objectives of this talk would be to speak about basic principles of preoperative assessment, to perform preoperative assessment in uncomplicated patient with special emphasis on general health assessment, cardio-respiratory assessment, medications and medical device assessment, drug allergies, pain relief needs, and then to categorize patients according to their risks. As we know, all patients who undergo surgery should be assessed in advance with view to the planning of optimal preparation and perioperative management. This is one of the important standards of quality of healthcare providing to surgical patients. Failure to undertake preoperative assessment places the patient at risk of perioperative morbidity and mortality. Why it is important to do a proper preoperative assessment? To anticipate potential problems, to ensure adequate facilities and personnel for managing problems, to ensure patient is correctly prepared for surgery, and to provide appropriate information to the patient, obtain an informed consent for the surgery and planned anesthetic technique, prescribe pre-medications, and to start specific prophylactic measures if it's necessary and required. For example, DVT prophylaxis or infective endocarditis prophylaxis, and finally to ensure proper documentation. How is this done? Usually we start with the basics blocks of preoperative assessment, which would include history taking, physical examination, investigations, risk stratifications, and then finally to develop a surgical and anesthetic plan. We're going to highlight important aspects about history taking. On history taking, we need to focus on presenting conditions to understand the indication of surgery and the urgency of the surgery, because many surgical conditions have systemic effects and these must be sought and quantified prior to the surgical intervention. The second important point in history taking is to identify the coexisting medical diseases, which usually affects the surgical and anesthetic plan. The most important and relevant evaluation would be for the cardiovascular and respiratory diseases. The inability to climb 2 flights of stairs is an indication for an increased risk for cardiac complication after major surgery. The same would be for limitation of exercises. In coexisting medical diseases, we need to do a full systemic evaluation and review and to focus on central nervous system, cardiovascular system, respiratory system, renal and hepatic diseases. The third facet in history taking is to focus on anesthetic history. And a detail of administration and outcome of previous anesthetic is always important. And also it is very important to highlight a serious problems which was encountered before, such as maintaining a patient airway or performing a tracheal intubation. Another important facet of history taking is to take an important information about drug history. So a complete history of concurrent medications are very important because many drugs interact with agents or techniques used during anesthesia, and problems may also occur if these drugs are withdrawn suddenly. So based on these data, the patient will be informed about what medication he or she should continue using or stop prior to surgery. Examples of cardiovascular system drugs which with a potential interaction during anesthesia are the angiotensin converting enzyme inhibitors, which might lead to severe hypertension. The same is true for angiotensin receptor blockers. Clonidine sudden withdrawal can lead to a hypertensive crisis. Beta blockers have a negative inotrope effect, and they mask compensatory tachycardia. And the acute withdrawal of these medications may result in angina or ventricular extrasystoles. Calcium channel blockers also have a negative inotropic effect. They might lead to bradycardia, and the acute withdrawal of these medications can exacerbate angina. So what should we do about medication which is taken before surgery? Most drugs should be continued up to and including the morning of the operation. Some adjustment in the dose may be required for some medications, such as the antihypertensives or the insulin, and some drugs should be discontinued several weeks before the surgery if feasible. Examples of these medications are the long-acting monoamine oxidase inhibitors, and the consideration must always be given to the potential consequences of stopping drugs preoperatively and the appropriate advice or alternative treatment provided to the patient. The fifth element of history taking are the history about any previous allergic reaction. And the history of allergy should be to specific substance, such as food, drugs, or latex. And for example, latex allergy requires specific equipment and preoperative management. Allergy to local anesthetic is usually a manifestation of anxiety or a response to peak concentration of local anesthetic or adrenaline. And a small number of individuals are allergic to sulphites, which are usually commonly found in local anesthetic preparation. So an important emphasis about these should be taken during allergy history evaluation. The sixth important aspects of history taking is the history of smoking. The long-term effect of these smoking on cardiovascular and respiratory system are well established, and this might lead to a six-fold increase in post-operative respiratory morbidity. The recommendation is to stop these smoking at least 2 hours prior to the surgery, and if smoking was stopped 6 weeks before the surgery, this will significantly reduce the bronchoconstriction and mucus secretion in the tracheobronchial tree. Also, an important evaluation of obstructive sleep apnea need to be considered on the preoperative assessment during history taking, because this have a higher incidence of difficult airway management and should have a careful observation in the postoperative period. And the gold standard for evaluation and diagnosis of this would be through polysomnography. And if it's not available, screening tools can be utilized, such as the Berlin or the Stop Bank questionnaire. The Stop Bank questionnaire will include these important evaluation, which is a question that can be directed to the patient, such as, do you snore loudly? Do you often feel tired, fatigued, or sleepy during the daytime? Has anyone observed you stop breathing during your sleep? Do you have or are you being treated for high blood pressure? And then evaluation of the BMI index, the age, the neck circumference, if it's more than 40 centimeters, and whether we're dealing with a male or a female gender. And the history risk of obstructive sleep apnea, if there was 3 positive answers to these questions from 8, this will signify the risk during anesthesia as well. So in summary of history obtaining for preoperative evaluation, it's very important not to underestimate the patient history. It's very important to evaluate coexisting medical conditions that may alter surgical or anesthetic plan. And it is very also important to understand which medication that can be stopped and which to be continued prior to the surgery, and to document any allergies and notify the team that the anesthetists are working with. What about physical examination? It is mandatory for all patients, and it should include general examination and airway assessment. The general examination will focus on nutritional status of the patient and the fluid balance, the temperature of the patient, condition of the skin and the mucous membranes, peripheral pulse, arterial blood pressures, heart sounds, and carotids bruit. And also, it's important to evaluate for any dependent edema, central versus peripheral cyanosis, observation of dyspnea, auscultation of the lung fields, and any dysfunction of the special senses, such as the cranial nerves or peripheral motor and sensory nerves. What about airway assessment? It's important to know the general appearance of the neck, face, maxilla, and mandible, to evaluate the jaw movement, also to evaluate the head extension and neck movement, to evaluate the condition of the teeth and the oropharynx, soft tissue of the neck, previous anesthetic record, which is of a great importance, and also to do some sort of airway tests. How we can assure or evaluate airway assessment prior to the surgical intervention. Many tests can predict the difficulty of laryngoscopy. None of these tests actually is totally reliable. However, there are important visual evaluation test, which is called Malam-Patty test, which is widely used and simple classification of the pharyngeal view obtained during maximal mouth opening and tongue protrusion. The predictive value of this test may be strengthened if the thyromental distance, which is the distance between the thyroid cartilage prominence to the bony point of the chin during full head extension, is evaluated. This slide shows the Malam-Patty test classification, which is based on the visual interpretation between the base of the tongue and the roof of the mouth, including the hard, soft palates, uvula, and pillar. And as we can see, it is classified from class 1 to class 4, indicating an increased possibility of morbidity with classes 3 and 4 during induction of anesthesia. So in summary of physical examination evaluation, it is mandatory for all patients, and airway assessment will give you the chance to predict difficulty and be prepared and anticipate any problems during the anesthesia. What about preoperative investigations? It's important to mention that routine laboratory tests in patients who are apparently healthy on the basis of the history and clinical examination are of little use and a waste of resources. Before ordering extensive investigation, the following questions should be considered. Will the investigation yield information not revealed by clinical assessment? Will the result of the investigations give additional information on diagnosis or prognosis relevant to the planned surgery? And will the result of the investigation alter the management of the patient? These questions are very important to be considered prior to ordering any sort of sophisticated investigation. This is a sort of a guidelines for preoperative investigation that preoperative assessment should include. It's recommended that all patients should have a urine analysis, a full blood count, especially in female gender, or patient with who's anticipated to have a significant blood loss, or when indicated clinically, such as history of blood loss. It's important also to request a urea creatinine and electrolyte in patients who are more than 65 years of age, or in a patient who has a cardiopulmonary disease, or patient with liver diseases, diabetes, or patient with diarrhea, vomiting, or metabolic disorders, or patient receiving fluid therapy for more than 24 hours. Also, it is very important to know the blood glucose level, especially in patients who are diabetics or have a vascular disease or taking corticosteroids. It's important to know about liver function tests in patients with liver disease or alcoholism, or previous history of hepatitis or abnormal nutritional status. Coagulation screening, it is important in patients with coagulation disorder, drug abuse, significant chronic alcohol abuse, or acute or chronic liver disease or anticoagulation medication. ECG is recommended in male smokers older than 45 years and all other older than 50 years. Any history or suspected history of heart disease or hypertension, patient taking medications for cardiovascular, systemic, or diuretic medications, or patient with chronic or acute and chronic pulmonary diseases. Lastly, the chest X-ray. It is rarely indicated unless active cardiac or respiratory disease is anticipated, and previous abnormal chest X-ray is not an indication in its own to repeat a chest X-ray. So in summary, there is no single preoperative test is mandatory for all patients apart from urine analysis, And you need only to request investigation that will change your management or add a new information for you in your assessment. Important points about preoperative risk stratification. After the patient history, examination, and relevant investigations have been collected, the anesthetist must answer two questions. Is the patient in the optimum physical condition for anesthesia and surgery? That's question number one. And question number two, are the anticipated benefits of surgery greater than the combined risks of undergoing anesthesia and surgery, taking into account any concurrent diseases? In principle, if there is any medical condition which may be improved, surgery should be postponed and the appropriate therapy should be instituted. At this stage, the patient should be reassessed and the decision about when or whether to proceed with the surgery need to be reviewed. What about risk stratification of patients? The prediction of preoperative mortality and morbidity are very important for the anesthetist before considering any surgical intervention. Usually there are scoring systems that can be utilized and can give an idea about risk stratification. The first one is the general scoring system, which is designed to predict nonspecific, undesirable events. Examples of these are the ASA system and the POSUM system. And we're going to highlight some points about it later. And specific scoring system, which focuses on prediction of specific morbidity or mortality or technical difficulty, such as adverse cardiac events or difficulty with tracheal intubation. American Society of Anesthesiologists have graded the patient into 4 major grades or classification according to an increasing risk of mortality. Class 1 is a normal healthy individual. Class 2 is a patient with mild systemic disease. Class 3 is a patient with a severe systemic disease. Class 4 is a patient with incapacitating systemic disease. And Class 5 is a morbid patient who is not expected to survive more than 24 hours. And Class E is a suffix for any kind of emergency procedures. The POSUM classification is a physiological and operative severity score for the enumeration of mortality and morbidity, and it depends on 12 major physiological factors in addition to 6 operative factors. And the summation of this can be calculated, if you'd like, through visiting this link. So in summary, the use of a standard scoring system, which is the ASA and or the OPSUM, to assess general risk of the surgery and anesthesia is very important for risk stratification before any surgical intervention. The use of specific scoring system to predict specific complication based on the patient's status and surgical intervention might be required. These are a few references and further reading for your evaluation, and thank you very much for giving me this opportunity. Good luck.